Good morning, good afternoon, good evening, everybody. My name is Janat Kar. I work at the Department of Environment, Climate Change and Health at the World Health Organization in Geneva. And I'm the moderator of today's webinar. Today we are launching our new publication, a framework for mental health and psychosocial support in nuclear emergencies, in radiological and nuclear emergencies. The second moderator, my co-moderator, is Dr. Fahmi Hanna. Fahmi, would you like to introduce yourself?
Janat, thank you very much and welcome everyone. My name is Fahmi Hanna and I work as a technical officer at the Department of Mental Health and Substance Use. I'd like to hand over for our director of the Department of Mental Health and Substance Use, Devora Kestel, for her opening remarks, please.
Thank you very much, Fahmi and Zanat and colleagues. A pleasure being here today with you all. So let me tell you briefly, how did we get here? And it starts over more than 2 decades when WHO has started to support mental health during emergencies. Initially by being directly present in several countries when needed, and later on by co-leading interagency efforts on mental health and psychosocial support in emergency settings. We have been providing support to countries during acute and protracted crises, and also in the meantime, in parallel, giving technical advice and guidance on policy and field activities, including on building or rebuilding community-based mental health systems after emergencies. And our work, WHO working on mental health, is guided by the Comprehensive Mental Health Action Plan that was developed in 2013 and was just extended to 2030. And this plan outlines actions and implementation options on many issues, including mental health in humanitarian emergencies. Now, on last April this year, the WHO Director General recommended that WHO country offices should prioritize the inclusion of mental health and psychosocial support as an integral and cross-cutting component of public health emergency responses. And this important suggestion by Dr. Tedros was actually agreed in December last year. So it was prior to COVID that we were already aware, and Dr. Tedros was aware of the importance of mental health and psychosocial support in the context of emergencies, including biological, chemical, nuclear, radiological, and ecological events. And now it is a well-known fact among those of us involved in this field, and especially during COVID-19 response, that MHPSS, as we call it, mental health and psychosocial support, should be an integral component of any acute or protracted emergency response. It is essential to note that MHPSS should be part of all emergency preparedness plans, as well as necessary elements of all efforts in recovery and in building back better after the emergency. Our Department of Mental Health and Substance Use, values the collaboration with the Department of Environment, Climate Change and Health, and the work with the Radiation and Health units within WHO on this specific product. We also thank the OECD Nuclear Energy Agency for the collaboration and for the technical inputs. So this excellent framework we are launching today has created a unique bridge of dialogue and cooperation between the field of mental health and psychosocial support in emergencies and the field of radiation and nuclear sciences. And this collaboration is a good role model and reflects the importance of our area as a cross-cutting issue that is relevant to health and other sectors as well. And it's also clear the significance of this topic in emergency preparedness. So today, with the launch of this framework, experts from both fields, MHPSS and nuclear and radiation, will get to know each other concepts and terminology, and more importantly, will be informed on actions to be implemented collaboratively together in case of a radiological or nuclear emergency. This framework makes us all better prepared on this subject to help people when required. We hope there are no more Chernobyl or Fukushimas, but we are better prepared in any case. I want to thank all radiation protection and mental health experts around the world who made this dialogue and this product possible. I thank you very much.
Thank you so much, Deborah. Without further ado, I would like to now welcome Dr. Maria Neira, the Director of the Department of Environment, Climate Change and Health, to deliver her opening remarks. You're welcome, Maria.
Thank you, Janet. Thank you very much. And dear all, let me join Deborah saying that it's really a pleasure to welcome you to the launch of this WHO framework for mental health and psychological support in radiological and nuclear emergencies. Deborah, mental health is always a priority in public health, but I'm afraid the times we are facing now describe how mental health is critical, and more than ever, we need to make sure that in this recovery, we are all part of and including on a very serious and important way the recovery of the mental health of our society. So we are 100% with you, and we are very happy that this benchmarking and quite unique, I think, document has been developed as a result of this interdepartmental collaboration between our Department on Environment, Climate Change and Health, and the mental health. I think it's and substance abuse. It's really an honor to have the opportunity to work with your department and others. And I think it means, once again, putting the interdisciplines together provide a very good results. And this one, working with the department as well of the health emergencies and conflict setting and natural disasters and outbreak communicable diseases and pandemic. It's clear that today we are learning many lessons from the COVID-19, or at least I hope we are learning many lessons from the COVID-19. For a few months ago already, in our department, we thought that at the same time that we need to keep fighting the virus and being the kind of firefighters on making sure that we will reduce the transmission and treat the patients caused by the coronavirus, we need to start to work on the recovery after COVID-19. And in that sense, we have prepared what we call it a manifesto, a WHO manifesto for a healthy and green recovery. And we included into that manifesto just 6 prescriptions that I think that if you read it, there are very common sense, wise, basic recommendations, making sure that now that the countries, the governments will allocate new stimulus packages and financial resources to this recovery, this health, economic and social recovery, we hope that those funds are going into the right direction. And those investments are making sure that we will put the basis for repairing, fixing those systemic failures that have been detected until now, and those that we need to repair if we really want to go back and build back better. Because if we go for the same mistakes that they took us to this situation in front of the COVID-19 outbreak, I don't think we are learning really the lessons. Now, among the lessons we need to learn is how to manage mental health and psychological impact of the response interventions. Obviously, what are we expecting to have as a result of these terrible physical distances that we are imposing, the quarantine, the isolation, the very traumatic lockdown in many countries. We need to learn as well the lessons of managing the infodemic, all of these the stigmatization of the patients and the affected people, and the lessons as well on how we could engage with community and as well solidarity, how we will deal with all of those experiences and lessons. But the good thing, if we can put it in this sense, we can learn from the Fukushima nuclear accident. Believe it or not, but it was already 10 years ago when Fukushima triple disaster occurred. Janet and I, we will remember very well, and many other people in the department, that day when we were called at 3 o'clock in the morning and we opened the shock room, the so-called shock room in WHO. That was a terrible time. And but 10 years later, we had health impact. We have a good report of what's happened after a nuclear accident. And obviously, it was not just the radiation exposure per se, but the social and particularly the psychological consequences of this emergency. People were terrified. People has been on anxiety and very unpleasant situation and not knowing how to protect themselves. And we need to learn now from those protective measures that we have put in place at that time and looking at the response. So the need for development of solutions to tackle such consequences became very prominent. And it was necessary to take an urgent action to address this need for public health policy and guidance and for managing the mental health and psychosocial impact of nuclear emergencies. In order to do that, we did not need to reinvent the wheel. That there was we took what already existed in terms of the normative tools and policies, and we used it by those that were used by the WHO in emergencies, and we adapted those for radiation emergency settings. And this work, I have to thank those who have been participating in the implementation and as part of the collaborative project with the Nuclear Energy Agency, OECD, of the OECD, and its working group, working party on nuclear emergency matters that place a high priority on the need for such international guidance and adding critical mass to the momentum created by WHO's advocacy efforts. And this, I have to say, is very, very much appreciated, and I thank you on behalf of WHO. This new framework is a very important step that reaches two fields, the radiation protection and the mental health, and has been really a pleasure to work with all of you. And it provides, I think, a foundation based on which we will need to build further. We need to develop now further tools. We need to offer training courses for responders, workers, for communicators, for other specialities, and those future tools will need to be integrated in the response plans. So we have a lot to do, and we have a lot of work ahead of us. We are, again, extremely grateful for the cooperation and support provided by the global expert community from both fields, the radiation and mental health, and as well those who took part in peer review processes and provided very, very valuable feedback. So we thank as well our panelists who agreed to participate in the launch today, and I hope you will find it very useful and interesting. I would like to thank as well all of you for joining from different regions of the world. Maybe I should start by saying good morning, good afternoon, good evening, as is the standard way in WHO now when we have our press briefings. And thanks for allocating your time. This is very, very much appreciated. And of course, this is the richness of WHO, counting on the professionality of the people around the world, the best experts, always responding in a positive way when WHO convene for something like this. So thank you, Jana. Thank you all for participating, and lovely. This is a very good event, so happy to be part of that, and congratulations to all. Thank you. Over to you.
Thank you so much, Maria. I really appreciate both of the directors' blessings, let's say, and sending us in the right direction. So we are now going ahead with the program. And within the program, the first presenter is Dr. Fahmi Hanna, who is doing the setting the scene for the launch of the framework. Fahmi is a psychiatrist by training, He previously served at the WHO offices in Syria and Libya, and since 2014 he is with headquarters in Geneva. He is our in-house technical lead for the mental health and emergencies area of work. Since 2017, Fahmi is a co-chair of the Interagency Standing Committee Reference Group for Mental Health and Psychosocial Support in Emergencies. Fahmi, you have 10 minutes. Floor is yours.
Shana, thank you very much, and I want to emphasize and echo what Maria has shared, that I remember back in 2018 when we started working on this document, there was a clear and wise decision from Jannat, from Matthias, and from Jacqueline and other colleagues at the OECD NEA when they started working on this, that you don't want to reinvent the wheel. You want to use what have been tested and used before in other emergencies in creating this framework. And this is what I'll focus on in my presentation now, what we had before and we are using in different emergencies. I hope you can all see my slides now. Perfect. So I'm starting with the objectives of WHO work on mental health and emergencies. There are three objectives. First, we want to integrate mental health and psychosocial support as an integral component of the WHO emergency program, emergency response and operations. Second, we want to use every emergency as an entry point, as an opportunity to strengthen mental health systems in countries during the recovery phase. Sometimes emergency is our only entry point, because mental health classically is a neglected area in many countries. And third, we want to develop policy, guidance, tools, and materials where we standardize the mental health and psychosocial support operations, not only within WHO, but also among UN agencies, international NGOs, by reaching consensus in this area of work. And here, what our framework today represent one of the tools where there was classically one of the gaps in this area of work. I'm stepping back here and explaining where the term mental health and psychosocial support come from. This composite term comes from the Interagency Standing Committee guidelines, released back in 2007, with interagency consensus among all UN agencies, international NGOs, and Red Cross and Red Crescent societies. The composite term mental health and psychosocial support remind us that this field in emergencies is not about disorders, is not only about diseases. It's a composite term that covers both ends of the spectrum, from prevention and treatment of mental health conditions to protection and promotion of psychosocial well-being. The IC guidelines of 2007, which represents a gold standard now in practice in this area of work that we use to adapt this framework, recommend to us also that we have multi-layered response. Not only clinical service, although clinical service is an important part of any response, but it lies at the peak of the pyramid. Not everyone would need clinical service, but everyone would need mental health and psychosocial considerations integrated to basic needs and security provision. Many people would need activation of social networks, which may be disrupted. Many people would need focused emotional support. And finally, some people, a very vulnerable group, would need clinical services. So the IC guidelines, one of its key principles is having multi-layered interventions, which we also emphasized in the framework. And I'm going here to give an overview on what are the minimum actions that Sphere Handbook is telling us that should be done by the health sector in emergencies. First, coordinate mental health and psychosocial support as a cross-cutting area. In good humanitarian practice, you would find actors working in education sector, doing, for example, school mental health promotion. Actors working in child protection, doing child-friendly services. Actor working on GBV, integrating the mental health and psychosocial aspects into the gender-based violence response. Actor working on health sector, integrating mental health into primary health care. In good humanitarian practice, a multi-sectoral, interagency, cross-cutting group, not under one specific sector or cluster, should exist as a cross-cutting group. And this also applies to radiation emergency. And in fact, during COVID-19 response now, in a survey done by WHO between June and August, we know that 2/3 of the countries of the world have similar platform for coordinating mental health and psychosocial support during COVID-19. Second principle, we started with coordination. Second one, always build your intervention based on assessment of available needs and resources. It's important to build on what exists, and to know what exists, you need to start by assessing what is in there. So that's why we have 4 W's: who is doing what, where, when, where we need always to start. And assessment is always linked to coordination. And there is also a WHO UNHCR toolkit for assessment. Another point, build capacity of everyone, all responders, 100% of all sectors, on basic psychosocial skills, including psychological first aid, for example. And I'm here putting an image of a similar tool adapted for COVID-19 response for all responders, not only health sector, but law enforcement, social sector, those who work in food distribution need to learn skills on basic psychosocial issues. Ensure that all community members, including marginalized people, learn about community self-help and social support. In an emergency like COVID-19, we have a wide range of materials for community support. From a self-help guide, doing what matters in times of stress to help people cope with stressors, to a children's storybook where parents can use to explain to children how to cope with stressors during COVID-19, to messages standardized by WHO and used as part of risk communication messages. Principle number 5, make sure that every healthcare facility, as a minimum, have one person trained and the system in place to treat people with mental health conditions. WHO have standardized tools for humanitarian operations to build the capacity of general healthcare workers, such as humanitarian intervention guide. And it's not only enough to train, it's important to have system in place to provide service for these vulnerable people. 6, make sure that you have a system for providing psychological interventions. There are evidence-based tools and manuals by WHO, can be used by lay worker, community workers on problem solving, on interpersonal therapy to help people, even without medication, to cope with stressor and even treat conditions such as depression and anxiety. 7, a group commonly forgotten, people in institutions. So do not forget the basic needs, the rights of people in institutions. 8, sometimes people self-medicate on drugs and alcohol during emergencies. Minimize the harm. And finally, use every emergency as an opportunity to build back sustainable, community-based, evidence-based mental health services. A flagship publication from WHO published few years back, called Building Back Better Sustainable Mental Health Care After Emergencies, with case studies from almost all WHO regions about countries used emergencies as an opportunity to build better systems. I think the framework we're launching today is key, is a good role model, as Devorah has mentioned in her presentation, for how mental health and psychosocial support should be an integral component of preparedness. It's a key preparedness document. We hope the world would never see Fukushima or Chernobyl again. So we hope we never use this document in emergency response, because we don't want to see these emergencies happening again. I think one of really the fruitful outcomes is the dialogue we had. We learned a lot as mental health experts from our interaction and work with colleagues like Jannat and other radiation nuclear colleagues. Even in our terminology, I remember in our discussions, I always forget to say the nuclear component after radiation, radiation and nuclear, and always Jannat used to forget saying psychosocial after mental. We learned how to complement the concept and terminology of one another and understand the field. And I learned a lot. The fact that we worked on this in 2018, and we were discussing issues such as stigma, isolation, quarantine, evacuation, displacement, livelihood affection, all this we were discussing. We know now that this is not only relevant for radiation emergencies, but this is relevant to many other emergencies as well. Thanks for the opportunity, and it was really a pleasure to work with you on this framework.
Thank you so much, Fahmi. Very good presentation. Indeed, we learned a lot during the process. And I'm happy to introduce our next speaker, who comes from the academia, who will give us some more detail on the scientific background for our work on the evidence base. It is our dear friend and collaborator, Professor Robin Goodwin, who is with the Department of Psychology at University of Warwick in England. Robin, the floor is yours. 10 minutes, please.
Thank you very much. Thank you. Can you, Zanat, can you put my slides up, please?
Yes, I'm going to share my screen.
And hello, everyone from the centre of England. Hello, everyone. So today I want to talk about risk factors for mental health in emergencies and some challenges for implementing intervention. As the new framework notes, radiation emergencies have several unique features. There's considerable uncertainty about the short and long-term health benefits, including some unexplained symptoms. However, they do share some commonalities with other emergencies. For most traumas, we can talk about an emergency life cycle, as described in the report. This includes not only, of course, the immediate responses to an event, but important factors, including prior preparedness, as well as the longer-term recovery. So what I want to do in my few minutes is briefly consider some features of preparedness, emergency, and the recovery stages. Next slide, please. So first of all, the before and preparedness. Nuclear plants such as Fukushima exist in physical environments which have their own risks, but also social and psychological environments. We know, for example, that there was fairly high rates of severe mental illness already in the Miyagi prefecture in the months before the 2011 earthquake and Fukushima disaster. Many facilities in the area already existed for vulnerable people who are elderly and disabled. Indeed, sensitive facilities are often placed in relatively remote areas which have some underlying challenges. It's therefore important to understand something about the local community. This includes, before any event, a mapping of who the vulnerable, both physical and psychological groups are, where they live, what they compose of. Are they already consisting of some groups which may be vulnerable to stigma, for example, perhaps on the basis of their ethnicity or other factors? It's important too to understand relations with the nuclear facility. That may include issues that might decrease or increase trust, and ideally to have some broader ideas of values of communities around the facility. The available resources too, the health services and personnel responders who can provide MHPSS in the case of emergencies. The established community structures such as religious groups or educational facilities that might be vital if they have to be drawn upon. And the media sources that are used or likely to be used in emergencies. Often they may differ across age groups, of course, with some social media being more appropriate for younger groups, as well as additional communication routes that can be identified, such as local news outlets, if they need to be used in a very quick way, ideally having some links with local editors and so forth. During emergency phase, there are immediate situational risks. Quite often in research on nuclear incidents, but also hurricanes, terror attacks, and so on, we can talk about the bullseye, those most in the center of an emergency that are most at risk. However, also those well outside the immediate threat, as we found with the 9/11 attacks, can feel very stressed by the mass media. There may be certain people at risk, frequently those who are the most vulnerable, the poorest, with less support from others and already with a poorer mental health. And there's always a risk of loss cycles, where people's money, status, healthcare, or relationships, according to conservation resources approaches, cycle into a downward decline. It's important during an emergency, of course, to have effective, comprehensible, trusted communications. And that's vital for getting to people to shelter in place or to evacuate from a particular situation. And of course, during that process, the role of myths and suspicions of fake news is very important. And that also may be influenced by resources. Those with little money may be motivated to reject the potentially costly actions involved, for example, of evacuating somewhere. So knowing about your community, feeding back into the preparedness stage is very important, because some groups may be very quick to reject advice if it's very costly to them. Next slide, please. After an event and a transition and longer-term recovery, well, it's important to notice that following mass trauma, most people, something between 2/3 and 3/4, do not suffer severe psychological distress. In our own data we collected with refugees in Miyagi, about 8% over a period of 6 years suffered from continuous severe mental illness, and another 8% got worse over time. So the great majority were relatively mild in terms of the psychological impacts. It's also important to remember there's no simple resilience process. There are important factors for recovery, but you cannot guarantee that these will always be the most significant. So important factors are things like the economic situation, group status, the risk of stigma, for example, maybe reflecting underlying discrimination that was there before the event. Housing. Displaced communities are often housed together. And that can be important because isolation is a real risk. And that relates to social support from families and friends, as well as the wider community. That wider social support can be compromised over time. According to the social support deterioration deterrent model, stresses and tensions that are developing during the period of a transition or longer-term recovery, often over resources and limited amounts of economic facilities, for example, can undermine support. Probably very important, but often neglected, that following an event, maintaining routines is very important. And that's sometimes compromised by the movements people have had to make outside their local areas. Those routines include both primary routines, for example, the opportunity for getting good sleep or good food, as well as the secondary social supportive ones. And any new ones, if we think particularly about the COVID situation, having to wear face masks in many situations people are not used to, but also that is something that people do following other types of emergencies too. Next slide, please. What are the implications of all this? Well, at the preparation stage, we need to know the vulnerability landscape, to know your area, how to reach those most at risk. It's not just the physical landscape and the geological threats, but also the psychological one too. In fact, this is all part of a UNDRR campaign at the moment around no such things as disasters. Their argument is that preparedness is always important and involves awareness of both the physical and psychological environments as a way of mitigating any particular event. Resilience evolves over time and is a mix of factors. It's no simple cultural personality effects, but instead it's a result of existing and emerging resources over time. These are physical, of course, economic factors, but also status, social networks, and so forth. Existing communities are important, but it's important not to exaggerate their impact. They are rather context specific to a particular event, as the WHO risk communication team has recently been talking about in some webinars. It's important to recognize that while communities are very valuable, there can be tensions within communities which lead to a reluctance to help, and that the leaders of communities may not be fully representative of everyone within that community. So communities are very important, but it's important not to over-exaggerate their impact according to the context. Next slide, please. And then also, the physical provision, of course, is important post-events. Supported housing, even if it's temporary housing, can build cohesion. Often we find that when people are placed together in temporary housing over time, they adapt to develop new communities. Interventions, both physical and psychological, however, involve commitment over time. Risk can cascade, particularly when health and economic support packages end, when it goes out the news cycle and people no longer pay attention to a particular area. It's important that interventions are sustained over a period of time. And then finally, there's a need for longitudinal research. And I turn here to my colleagues at the Fukushima Health Management Survey, who have provided really valuable and unique, in terms of quantity and quality, excellent data that have looked over a long period of time following the Fukushima incident. Thank you. I think that's my final slide.
Yes.
If anyone wants copies of papers around this area, I'm very happy to send things around the work we've been doing. Thank you very much.
Thank you, Robin. Fahmi?
Robin, great presentation and insights. Thank you very much. And learned lessons from previous emergencies is extremely important, and particularly important in this subject we're discussing today. And we are really glad that we have Professor Masaharu Maeda, professor and chair of the Department of Disaster Psychiatry in Fukushima Medical University School of Medicine in Fukushima, Japan, to share with us the experience in the response in Fukushima. Professor, floor is yours.
Thank you for for your introduction. I'm a psychiatrist, and I'm from Fukushima Medical University. And I've been engaging in providing psychological care for evacuees, and especially in charge of major mental health surveys conducted by our university. I would like to talk about mental health care after nuclear crisis based on my experience. This slide shows differences between natural and nuclear disasters. There are many differences between natural and nuclear disasters. Compared to natural disasters, in major nuclear disasters, such as Fukushima disasters, impact of trauma is more chronic and complicated. In Fukushima disaster, affected area is invisible and unclear. For example, we cannot make a definite clear borderline between affected and non-affected area. It should be very difficult for evacuees to accept physical losses compared to natural disasters. In addition, as Dr. Robbins stated, widespread public stigma toward radiation exposure and monetary compensation were often induced. Such social reactions are almost never seen in natural disasters. I would like to talk about initial phase after nuclear crisis. Adequate risk communication is required, but extremely difficult in this phase. Asking the public to keep calm often provokes negative reactions among them. It could be regarded as underestimation or concealment. Acute stress reactions often appear with intense aggression, which could traumatize different rescue and relief workers, including medical and welfare staff. A pre-existing care system should be weakened due to evacuation of health professionals. They also should be very scared. Alternatively, new mental health care system that can provide long-term psychological care in disaster area might be needed. In many cases, psychological first aid, PFA, can be effective. Training in advance is required. Actually, in Fukushima, two major facilities to provide long-term mental health care were established 10 months after the accident. One is a Radiation Medical Science Center in Fukushima Medical University, and another is Fukushima Center for Disaster Mental Health, as shown in this slide. The former had the purpose to implement long-term health surveys, and the later have been providing mainly visit service. Both employed many professionals who gathered from different places across Japan. This slide shows the principles of PFA, psychological first aid. PFA can be a universal useful skills for not only in case of nuclear disasters. However, understanding and training of PFA before disasters are very important. Preparedness is very important. Next, I'd like to talk about the recovery phase after a nuclear crisis. That phase is much longer than that of nuclear disasters. While risk communication is implemented, concerns among affected people extend to not only radiation health effects, but also other broad matters. Evacuation-related health issues, including suicide, should be growing up. Stigmatization emerges between the public and affected people. Disposal of evacuees might weaken community ties. This slide shows the changes of evacuation area in Fukushima. The number of evacuees reached over 1,000 at maximum. As the relief process, including decontamination progressed, habitable areas have been increasing. This slide shows changes of the number of evacuees who were evacuated inside and outside of Fukushima. While the number of evacuees inside Fukushima decreased yearly, that of those outside Fukushima decreased only a little. Even now, there are still nearly 40,000 people relocating far from their original town. In the initial but not brief phase of the Fukushima disaster, while most people and experts focused on only the direct effects of radiation exposure, such as thyroid cancer or leukemia, other health risks were ignored or seldom considered. However, as time passed, a variety of non-radiological health problems gradually emerged. As you can see, in contrast to two prefectures mainly affected by tsunami, only Fukushima Prefecture has a great proportion of indirect deaths. We call that disaster-related deaths, resulting from long-term evacuation. Unfortunately, until now, over 2,000 people died from various chronic illness, such as diabetes or hypertension, led by a long-term evacuation. Also, this slide shows the number of disaster-related suicides in three prefectures. Similar to the previous slide, the total number of disaster-related suicides in Fukushima reached 140, which is much higher than those in other affected prefectures. As you can see, different to other prefectures in Fukushima, the number of the suicide reached its peak 3 years after the accident. This delayed effect indicates a stressful life of long-term evacuation. According to our survey, prevalence rates of probable depression among evacuees stayed outside of Fukushima is higher than that among those inside. Relocation to remote area might distress many people due to unfamiliar situations. Next, I'd like to talk about the approach to those evacuated in remote area. Outreach, especially business service, is often difficult. By the way, telecommunication using telephone or internet is very useful. Sharing correct information about current situation is needed. A multidisciplinary approach is required. Actually, we Radiation Medical Science Center in Fukushima University has a support team consisting of 17 health professionals, such as clinical psychologists, social workers, and public health nurses. They have been performing telephonic interventions for evacuees identified at the risk of some mental health problems, such as depression, based on the results of our survey. The total number of those who received these telephonic interventions reached over 30,000 in total. Anyway, we should deal with different mental health issues for long time after a nuclear crisis. If an accident is serious, it could need even 1 or 2 decades. The last things I would like to emphasize is that such a long-term recovery process might bring substantial psychological burden to different workers working in disaster area. For example, our interview survey for public employees working in disaster area reveals that surprisingly, nearly 80% were diagnosed as depression due to exposed to intense anger among the evacuees. Continuous support for various workers working for long-term relief work should be required after nuclear disasters, as well as residents and evacuees. Thank you for attention.
Professor Maida, really thank you for your impressive and comprehensive presentation and response. Your work really was a good reference for us while we're working on the framework. So thank you and your team very much for this. And now we move to presentation by my colleague Dr. Zanat Kar. And Zanat, your vision and your advocacy to make sure that mental health and psychosocial support is included in the response to radiation emergencies was key, is really what brought us here today. Janat is the technical lead for the area of radiation emergency preparedness and response at the Department of Environmental Climate Change and Health. Janat is also the lead of the network of WHO REMPAN. REMPAN is Radiation Emergencies Medical Preparedness and Assistance Network. Now all the mental health team knows this abbreviation very well. And Jannat is a radiation oncologist by training and has been with WHO since 2002. Jannat, floor is yours.
Thank you very much, Fahmi. We are running a little bit behind the schedule, so I'm going directly to the presentation. I'm sharing my screen. Going to the full screen mode. Can you see it now? Yes? Okay.
We see it, yes.
Excellent. So I'm going to skip a couple of first slides because it's been already well represented. The fact that mental health and psychosocial impact of emergencies is well documented. Also the fact that WHO, as a part of the interagency standing group, has developed a lot of normative documents, and these are being used worldwide in various conflicts, emergencies, disasters, etc. For radiological and nuclear emergencies, we also have a very well-developed system of international arrangements, which is based on norms and standards. And the leading agency for this is IAEA, and we appreciate also the agency's cooperation on all matters pertaining to preparedness and response to radiological and nuclear emergencies. This system of existing arrangements is based on a very strong evidence, which is outlined in the UNSCIA reports, also is well represented in benchmarking reports of the International Commission for Radiological Protection, and further on in the International Safety Guides and fundamentals and safety standards, some of which WHO has co-sponsored, notably such publications as Preparedness and Response for Nuclear Radiological Emergency, Generic Safety Standard GSR Part 7, Generic Safety Requirements Part 7. This document actually has a very clear requirement for addressing psychosocial needs of population, affected population and responders during the emergencies and in recovery phase. However, we do not have really detailed explanations how this should be done, at which point, and who should be doing this. In turn, as already Fahmi explained to us, there is also very well developed normative and standard system for managing mental health and psychosocial impact of emergencies. So these two different areas so far have not been actually used together. What we've been that they exist in parallel universes, and we really are struggling for incorporating one into another. So this document, what we worked on, was a really first attempt to cross-fertilize these two fields. And it goes back to our discussion at the last REMPAN meeting, which took place in Geneva in 2017, where we had a special session dedicated to psychosocial impact and risk communication for radiological nuclear emergencies. And at that point, Mark van Nommeren, who is the coordinator of the unit dealing with mental health and emergencies, he delivered a very remarkable presentation where and all experts attending the meeting, we discussed it and we agreed that we really need to put all existing documents we developed for managing mental health and emergencies and to adapt them for the nuclear emergency settings. And this is what has been done. WHO has been advocating for this in numerous meetings and scientific fora. And I should really acknowledge the contribution and support and inspiration given us by Wolfgang Weiss. Many of you know this person is a legendary person in the field of radiation protection, a very prominent internationally well-known scientist who has been really pushing for this issue to be addressed, and first of all by WHO, because this is related to public health, and this is what is the mandate of WHO. So thanks to Wolfgang's support, we took this forward and the work started. Actually, as Fahmi already mentioned, this really gave us a good momentum and accelerated work forward when the Working Party of Nuclear Emergency Matters, WPNM, of the NEA put this issue as a priority on the agenda and invited WHO to discuss how we can take this further. So this became a joint project under which first part of the project was development by WHO independently, it is WHO document with, of course, support of numerous experts worldwide, including those experts who participate in WPNM, and personally, Jacqueline, who will be also talking later at this webinar. So we've been working since 2018 together, and as a second phase, as a follow-up of this framework development, we will be then looking into development of practical tools and practical solutions for emergency planners and responders. This is the timeline of how it all developed. I should notice that the document underwent rigorous reviews, peer reviews by the agency's IPRES committee members, by NEA's WPNM group members, also by the members of the HERCA, which is the heads of radiation protection authorities of European countries, and the REMPAN network. And of course, mental health experts also were approached to provide the comments and reviews. And we really appreciate everyone's feedback and comments and help to make this document what it has become. So roughly to show you quickly the structure of it, we of course start from introduction, then we have an outline on what are the mental health and psychosocial consequences of radiological nuclear emergencies, why they are special and what makes them special. Then we originally we wanted to go through each emergency cycle through the planning and response and recovery. And then we realized there are a number of issues which will be coming up repeatedly in when we talk about every phase of the emergency. So based on that, we singled out those cross-cutting issues and we put them up front of the document as a standalone chapter, and we call them 5 C's. So coordination, communication, capacity building, community engagement, and core ethical principles approaches for considering mental health and psychosocial support. And then we address each of the emergency phases, preparedness, response, and recovery. And we discuss about the challenges in implementation of MHPSS. And also we, as most of WHO documents include this section on research priorities and needs, because we should always look forward what is the next step after publication. So these are the 5 C's. Coordination is a very important factor. It is also put up front in both in GSR Part 7 publication. The cross-sector coordination is being underlined as a key important factor in preparedness and responding to emergencies. It is also one of the very first and prominent requirements by the international health regulations. Cross-sector coordination is the key for response to any emergencies. Communication is cannot be overemphasized. Everybody agrees, and it's well known factor that communication is a key, both for communicating to public, communicating between responders, communicating the risks, and WHO has issued the guidelines on crisis communication for public health, and we are heavily referencing that document in our framework. Community engagement is extremely important component, and we also see now during the response to a COVID pandemic how community engagement is coming more prominent and becoming one of the key response components. Capacity building also a very important component, and this is for all actors and players involved in response, of course, health workers, but also responders from different sectors who should be aware of mental health and psychosocial support requirements. And core ethics, we have a section in the framework elaborating on the core ethical approaches, and we use as a basis the approaches used by radiation protection, and we also add those principles which are included in the MHPSS normative documents. So for the purpose of our document, we actually put urgent response and early response phases together in one emergency response phase. And we also group transition phase and recovery phase in the one post-emergency phase. So the chapters are dealing with key elements of planning for MHPSS. The next chapter talks about considerations during the response phase, and special chapter dealing with considerations for post-emergency, medium and long-term recovery phases. So the key messages for the of their framework are basically what we said is that radiation emergencies have unique mental health impact, that these include fear, anxiety, emotional behavioral changes after emergencies, and they often outweigh the direct impact of the exposure to radiation. A public health approach with an emphasis on MHPSS interventions is essential for planning and effectively responding to radiation emergencies, and must include interdisciplinary capacity building apologies, just moving some little thing square on my screen, because otherwise it's blocking my screen. I cannot see what the text on the screen, and responding effectively. So these interventions should be carried out while ensuring that radiation emergency protective actions are implemented, are not jeopardized, to reduce the risk of radiation exposure for the affected people. Cross-sector coordination I already mentioned. It is extremely important between radiation protection and MHPSS actors. Also, community engagement and targeted risk communication and applying core ethics principles are crucial for effective preparedness, response, and recovery after the emergencies. We will need to focus on development of practical tools to further promote and implement integration of MHPSS within existing radiation emergency preparedness plans and protection actions. And further research is needed to understand mental health vulnerability to radiation emergencies and strengthen the evidence base for appropriate MHPSS actions. This is the screenshot of the acknowledgement page from our framework, and I cannot thank enough all the contributors, reviewers, and also I want to mark especially our graphics designers and the technical editors who's done excellent job developing this document. Thank you very much for your attention. I stop sharing here. And
Janat, thank you very much. Excellent presentation, and really the document is an excellent model for how MHPSS can be integrated into preparedness, but also into the whole emergency cycle. I would like to move now to a colleague from the Red Cross movement, and the Red Cross is one of the leading agencies in providing mental health and psychosocial support globally. And today we have Sara Hedrenius from the Swedish Red Cross. She is a senior advisor on mental health and psychosocial support. Sara, please. Sara, I think you are on mute. We cannot hear you.
Okay, can you hear me now?
Now we can hear you. Thank you.
Yeah. Thank you. So sorry, I have had some technical problem this morning and my camera is not working. So unfortunately, you can't see me, but you can hear me now. That's good. And you can see my slides? Yes.
Yes, we can see it. Thank you.
Okay. So the International Red Cross and Red Crescent movement, which I represent today, is stepping up in this area. As you said, we want to do even more and do better. So we are scaling up. My name is Sara Hedrenius. I'm a senior advisor in mental health and psychosocial support based in Swedish Red Cross. That's my background. I also copy-paste a photo of me so you can see that I'm a middle-aged woman with dark hair doing this presentation, even though you can't see me. The strength of the Red Cross Red Crescent family is that we have around 13.1 million volunteers around the globe, and they are based in different national societies around, and they are actually also connected to their local branches, meaning that they are very locally based around the globe. So those are the ones that carry out the work that we do. And the past year, in December 2019, the Red Cross Red Crescent movement, we adopted a resolution addressing mental health and psychosocial needs for people affected by armed conflicts, natural disasters, and other emergencies. And that was adopted by 196 states, meaning that we will, together with them, the coming years, move forward and put our positions within this field. And we believe, and we very much welcome your framework, the new WHO framework of nuclear disasters and radiological disasters. That can be really helpful for us in our continuing planning. Today, I will give you a brief overview of what we are doing right now in the Red Cross Red Crescent movement, and that will be also aligned with the SWER guidelines and also the ISAC guidelines and the framework that is already done. So I will show you how the Red Cross movement is doing it and how that also will be linked to your new framework. Our new policy contains 8 policy statements, and that is to ensure impartial access to mental health and psychosocial support, but also to prioritize prevention and early response, because that's very significant of our movement. We need to ensure comprehensive and integrated support and care for people with mental health and psychosocial needs. We need to recognize the resilience, participation, and diversity of people in all mental health and psychosocial activities, and ensure protection, safety, dignity, and rights, but also address stigma, exclusion, and discrimination while doing all this work. Implement and contribute to the development of the interventions based on mental health and psychosocial support standards and practices that are internationally recognized and informed by evidence, as you also discussed before. And also to protect the mental health and psychosocial well-being of staff and volunteers. Develop mental health and psychosocial support capacity. And that is crucial for us because we believe that we need to increase our workforce, and we need to be many, many more, and we need also to build up the capacity among our workforce and to train them better and to prepare them better for the next steps. And for us, this is something new, that we have a joint policy for the whole movement, bridging over between the IFRC, which is the umbrella for all the 191 different national societies, but also the ICRC, the International Red Cross Committee, that is operating also in conflict areas. So we have a joint policy, and that will make it more easy for us to work together with other partners and stakeholders. This is our new framework. It reflects the integrated approach that we have when it comes to psychosocial support. And we have this different levels of interventions. And you can see at the bottom line, you have the basic psychosocial support. And that is supposed to reach, I guess, all the people affected in an emergency, for example. And one example is, for example, in Swedish Red Cross, we do train all our volunteers in psychological first aid, as also was mentioned before, so that everyone is prepared for the first step. But then on the next level of this focused psychosocial support, we target people at risk. That goes for both individuals, communities, and families and groups. And then at the third level, the psychological support level, then we also operate together with volunteers that are specially trained. They have a background within the field. They can do special operations, but also staff doing this. On the top level, we have the specialized mental health care, and there you have professionals working. They are also connected to the healthcare system somehow, so they can be quality assured. This is the way we operate. And I think this goes in line with what you have discussed earlier today. And it is, I think it's a welcome initiative, and I think you can count on us, and we will step up and we'll bring your framework into our movement and spread it. To use the experience that you showed us today with former experience from different nuclear disasters. Thank you very much.
Thank you, Sarah. Very, very nice to hear this type of encouraging comments from our partners and stakeholders. The next stakeholder I would like to comment in the remaining time of the webinar is our very important collaborator for implementing this specific project. This is Ms. Jacqueline Garnier-Laplace from the Division of Radiological Protection and Human Aspects of Nuclear Safety of the Nuclear Energy Agency, OECD, in Paris. Jacqueline, would you like me to share your slides?
Yeah, please. Thank you very much, Zanat. Thank you, and good morning or good afternoon or good evening to all of you around the planet. I'm really very pleased, honored to deliver a view on behalf of the Nuclear Energy Agency about this new WHO framework. I have worked on the review of the document last January with Fahmi and Zanat, and I have to really say that it was a very pleasant, fruitful, and constructive experience where in the middle of those two very important persons, I learned a lot. So I'm sure that this publication will become very quickly a best of in the field of radiological protection and even wider. So next slide, please. First of all, let me try to explain why is this framework unique. The path from the recognition of mental health and psychosocial impacts of nuclear or radiological accidents to their mitigation in practice may be viewed as too long and too complex. Actually, such effects were reported after all nuclear or radiological accidents, even though they were all very distinct from each other. Such effects were embedded into the wording of non-radiological health impacts, and this highlights their multifactorial features. Now they are well recognized by all international organizations, which is great, up to the level of international standards, since their mitigation is among the requirements of the IAA GSR Part 7. These impacts often manifest themselves in individuals and communities in the form of mental health and psychosocial consequences associated with medium to long-term socio-economic disruptions. They are generally related to protective actions decisions. They are clearly evidence the lack of preparedness, and I think we are all in agreement with that. Next slide, please. Until this new WHO publication, we can say that there were no international comprehensive framework addressing this issue. So the WHO framework is, for me, even more than a comprehensive guideline, since it represents a major breakthrough and a first step bridging the gap between disaster risk reduction sector and nuclear emergency preparedness and response, and I would add recovery sector. Actually, it was a real smart strategy that was adopted by WHO to make use of their wide experience as co-leaders of the Interagency Standing Committee by getting inspiration from guidelines for providing MHPSS in emergency settings. And as such, I believe that this framework will serve as a basis for developing derivative products, mainly practical tools and solutions, which can be readily integrated into an whole hazard approach for nuclear emergency preparedness and response. And this is really an asset. Next slide, please. Now let's try to discuss whether there is still missing pieces. Obviously, the answer is yes. Actually, the Committee on Radiological Protection and Public Health, which is one of the standing technical committee of the Nuclear Energy Agency, has launched last year a dedicated expert group on this issue. And this expert group has the mandate to supplement the WHO framework by contributing to the development of such practical approaches. These developments have started on the basis of some national experiences and from the finding of 2 web-based events organized last summer, because we believe that it was timely to capture lessons from non-nuclear crises, such as obviously the COVID-19 pandemic. So you will find the summary, a summary leaflet on the right hand and on our website. So having said that, the ongoing work, a kind of challenge that is tackled by the expert group, I would like to acknowledge the hard work there, is to integrate mental health and psychosocial support into protective action decision making. And we believe that it is time to develop methods for balancing direct radiation-induced health risk against the indirect consequences of protective actions. For example, balancing the risk of immediate evacuation of hospitalized people or elderly against the possible benefits of sheltering in place with continuous care, for example. Second, consider impacts on the most vulnerable groups. We have to make decisions using the knowledge we've got on the various differences of sensitivity existing among population and age group. Then a key element is to provide more effective risk communication, where we could develop approaches for 2 complementary axes. The first one is to provide people with knowledge on health risk from radiation exposure in order they will be able to make their own answer to the question, am I safe? And second, know how to make the decision-making process more consensual among the various stakeholders. Make the best use of international good practice of MHPSS operation, and if so, adapt them to improve national and local plans and procedures, integrating, among others, cultural features. We have also to integrate logistical aspects in preparedness, such as access to healthcare or public services to citizens, maintaining that. And finally, not at least but not last, to be able to assess through metrics and to measure the efficacy of mental health and psychosocial support through certainly exercising more this issue and try to assess if national and community resilience are sufficiently developed, not so easy to do in terms of practical aspects. So just to conclude, I would like to say that now the WHO framework is on our table and will certainly serve as a catalyst to modernize preparedness, response, and recovery of nuclear and radiological accident. The Nuclear Energy Agency and its member countries involved mainly in the Working Party of Nuclear Emergency Matters and the expert group I was speaking about are really supportive of the work still to be done, and they are also really aware that it will be a challenge. And this is a good opportunity to enhance even more, if possible, the collaboration the NEA has got with the WHO. With that, I really thank you so much for your attention.
I'm muting myself. Thank you very much, Jacqueline. I really appreciate your kind words, and we also will look forward to taking this achievement further and joining our efforts to offer our member states some practical solutions for implementing the framework. And now I would really like to hear the view of one of our member states representative, Matthias Zaringer, who is the head of the Division of Emergency Preparedness and Response at the Federal Office of Radiation Protection, BFS, Germany. Matthias, can you hear us? Are you connected?
Yes. Can you hear me?
Yes, please give us.
Yes, thank you for giving me the floor, and apologies for I have not prepared slides, and I want to make it short because I also see that we are well advanced in time. But just say that I'm speaking here not only on behalf of BFS in Germany, but also as chair of the WPNEM, the Working Party on Nuclear Emergency Matters, and this is somehow entangled. Now, as for the Federal Office for Radiation Protection, we are a collaborating center to the WHO, and we have a broad spectrum of topics related to radiation. And in all these topics, social and psychological and communication issues are cross-cutting issues to be discussed. And I'm quite happy that we have here also added the field of emergency preparedness and response into this collaboration. And it was a great pleasure for me to work with you, especially Zanat and Fahmi, and my congratulations to this document. It's a big progress, and I appreciate this. Now, as for the situation in Germany, I mean, I don't want to echo so much what has been said before, that psychosocial support has to be integrated into emergency preparedness to nuclear responses. This is something that had already been known even before Fukushima, but Fukushima was certainly the trigger. And in Germany, we started to refurbish emergency preparedness. And we are now on the road since 9 years. And there have been low-hanging and high-hanging fruits. And I think it's safe to say that one of the most highest hanging fruits indeed is the integration of psychosocial support into emergency preparedness. Now it's, and one of my, I think it was Sanat, you were saying something about two parallel universes on the international level. This is certainly also true on the national level, not saying this so drastically, but indeed it's and we have learned this from our Swedish colleague, that psychosocial support is an integral part in emergency preparedness as far as non-nuclear issues are touched. And there are good concepts, and this is also the case in Germany, that psychosocial support is an integral part into disaster management. People are well trained, but the problem is to bridge, to have a bridge between radiation protection people and non-nuclear disaster management. I think this is the big, and this is also the big step forward of this publication, of this framework, that it is bridging. That's the key. And it's not about inventing the wheel twice. We have to adopt well-established concepts in mental health, but we have to start to be building a bridge. Now, in concrete, and this has also been said, that we now need more tangible results, we need more practical guidelines and all these things. For me, it also means in practice to establish dialogues. It's not only the plan, the important is the planning process. We have to bring people together, and we have to bring communities together. Drafting of this document was a good opportunity where we'll continue, and Jacqueline already draw a roadmap where we as WPNEM are going further to establish this dialogue. And let me in this context also mention a workshop we had been planning in March this year towards a better integration of non-radiological public health aspects of protection strategies during radiation emergencies, planning, response, and recovery. This was or is still planned as a joint workshop with WHO, NEA, and BFS. We had, because of the COVID situation, we had to postpone it, but it's not canceled. And I hope we will soon find a new date to bring people really together, to bring them physically together, to exchange ideas in an interdisciplinary dialogue. That's essential. Another thing I would like to mention is regarding to the NEA. The International INEX exercises is also a brand mark of this organization, in particular of the Working Party on Nuclear Emergency Matters. And we are now going ahead to plan the next series of exercises. And I'm quite confident that we can integrate in these exercises also aspects of mental health and psychosocial support, particularly because we are going to focus the next exercise generation to the recovery phase and late phase. And I think automatically in this phase, these issues will come up. So I'm really looking forward to see this document, the WH framework, as one of the key documents we can rely upon in developing new further documents, exercises, dialogues, workshops, and so on and so on. So thank you very much to WHO for this document. And with this, I conclude my contribution.
Thank you so much, Matthias. The member states' views are very important for us. We are here to serve our member states. And we also look forward to further collaboration with WPNM and you as a chair of that group. And I think it's really exciting to hear about your plans to incorporate the MHPSS elements in the next INEX exercises. It will be really interesting to see how that evolves. So we basically concluded the program of the webinar, and being a moderator, I am guilty in not explaining upfront that this webinar is being recorded and it will be made available for those who couldn't connect or couldn't see the entire event. There are some questions in the discussion in the chat asking whether the presentations will be made available. Yes, on the event website, we will put the PDFs of presentations and the video recording of the event. We also have two interesting questions which were asked. But unfortunately, we do not have time now to get into the discussion and answering the questions, because the point of the webinar was to present the document. We are very happy to connect afterwards by email and to get into more detailed discussions. With that, I would like to pass the floor to the head of the Radiation and Health Unit of the WHO headquarters, Dr. Emily van Deventer, who will say some closing remarks. Emily?
Thank you, Jeannette. Can you hear me?
Yes, very well, and see you.
Thank you. Well, it's been really a pleasure to work on this document with all of you. And as was mentioned several times today, this is a timely, necessary, and cross-cutting framework that brings together several elements, both from the mental health topic and the radiation topic. And some would consider this area really as a niche, as a rare set of events that could happen, and hopefully will not happen, as we mentioned. But this being said, integration into the overall health emergency preparedness framework is really key. So we were very happy to be able to set the scene for you for the need of such a framework, providing a summary of the framework itself from the mental health perspective and the radiation perspective. And also, I thought it was really helpful to hear from the stakeholders, whether it be from a member state or another organization or the Red Cross for that matter. And we're very much looking forward to derivative products, as were mentioned by Jacqueline. So from a WHO perspective, we are in a unique position to work with the ministries of health from around the world to disseminate this work. But as interested parties, you as participants around this table, if you wish, your help in distributing and disseminating this framework would be very much welcome. So we would like to thank you for your participation today and hope that this is just a beginning for further discussion on this topic. Thank you very much. And with this, I would like to close the meeting on behalf of WHO. Thank you.
Thank you so much, Emily. Thank you everybody for joining. And best regards to all. And we will be sharing the slides and the video recording on the events page in a few days, not immediately, but eventually. Thank you. Bye-bye.
Thank you, Jannat. Thank you, everyone.
Thank you.
Thank you.
Bye-bye.